Hello everybody, welcome to the Atrial Fibrillation Virtual Education Summit presented by Johns Hopkins University School of Medicine at CardioCare Live. My name is Dr. Michael Blaha, and you are tuned in to a live session called The Changing Landscape of Atrial Fibrillation Management with Dr. Hugh Calkins. Dr. Calkins is the Nicholas J. Fortuin Professor of Cardiology and Professor of Medicine at the Johns Hopkins University School of Medicine. He is also the Director of the Arrhythmia Service in the Electrophysiology Laboratory at the Johns Hopkins Hospital. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen, and I'll share them with Dr. Calkins. So Dr. Calkins, want to get us started talking about atrial fibrillation today?
Great. Well, I'm glad to be here, and it's a beautiful day here in Baltimore. So what I'd like to do over the next really 20 to 30 minutes is give you an overview initially of atrial fibrillation, talk about its importance as a disease entity. Then we're going to concentrate on the issue of stroke risk and anticoagulation. We'll touch on the management strategies, rate control, antiarrhythmic drug therapy, and catheter ablation. Now, some of these topics will be gone into far greater detail later on in this seminar or these series of lectures, and then I'll draw things to conclusion. We should have plenty of time for questions because it's always an interesting topic. So I have no conflicts of interest. Now, when you think about the epidemiology, it's striking how common atrial fibrillation is. It's the most common cardiac arrhythmia. It currently is said to affect about 5 million Americans, and it's estimated that by 2050 there will be 12 million Americans with atrial fibrillation. This reflects both the grain of the population, the age of the population, also the epidemic of obesity, which is occurring, and hypertension, and other important comorbidities. And it's sort of striking. If you think of anyone at the age of 40, there's about a 1 in 4 chance they'll develop atrial fibrillation over the rest of their life. So, it's just amazing when you start talking to your friends and your colleagues. There's lots of patients with atrial fibrillation. Now, atrial fibrillation is important for many reasons. It importantly increases the risk of stroke, and it's one of the most common causes of stroke. And I think it's said that of patients with atrial fibrillation, your risk of stroke overall goes up. And most strokes that occur with atrial fibrillation, are not a small stroke that affects your small finger on your left hand. They're strokes that render you aphasic, paraplegic, or that literally are lethal. So it's a very important consideration. Atrial fibrillation is important from a sort of a health economics or a healthcare perspective because it's what's filling up the hospitals. If you look at all the types of arrhythmias for which patients are hospitalized, you can see on this slide that AFib is by far, the number one problem that's filling up our hospitals. AFib also increases mortality. Now, this is data showing the impact of AFib on mortality. And I think, we all know that VF increases mortality, but I think many physicians are unaware of the link between AFib and increased mortality. And some would argue, well, this is old data, and what does modern data show? Well, it turns out there's a paper very recently published that highlights even today. This is a study where they took two big databases of patients, the ERIC study and another cardiovascular health study, where they follow patients over many, many years. And you can see in the highlighted red box that by having AFib, your mortality is increased significantly, but also your risk of sudden cardiac death. And whether this is AFib causing sudden cardiac death by short, long sequences, whether it's AFib causing sudden death by indirectly causing more cardiomyopathy, we aren't quite sure, but I think this was an important study. Now, AFib also is associated with dementia. And if you say what's new in sort of the AFib world, it's the awareness of those caring for patients with AFib of the link with dementia. Now, this is a study that was done, in Salt Lake City, where they looked at patients with and without AFib, and they compared their incidence of various types of dementia, non-specific dementia, Alzheimer's dementia, and so forth. And what you can see that patients with atrial fibrillation have a much higher risk of dementia. Now, you may say, oh my goodness, that AFib is causing dementia. I think it's a little bit early to make that statement, but we certainly know that atrial fibrillation and atrial fibrillation are somehow linked, whether this is caused by impacting blood flow to the brain, whether this is small silent strokes, so what the mechanism is, we aren't quite sure, but I think this is something that you're going to hear a lot more about in the years ahead, because this is a very hot area for research. Now, I think we all know that AFib reduces quality of life, and this is a study that looks at patients with atrial fibrillation, shown in the the green sort of lines, with patients with other kinds of heart disease, heart failure shown in purple, the normal population. And when you look at the various components of quality of life, whether it's physical functioning, vitality, general health, emotional health, whatever it is, you can appreciate that patients with AFib, their quality of life is reduced. And certainly the most important reason why we treat AFib today, we try to get rid of AFib, is to improve quality of life. Now, we'd like to think that we're going to improve mortality, we're going to prevent dementia, and these other sorts of things, but those are really unproven. What is proven is if someone feels poorly from atrial fibrillation, you get rid of the atrial fibrillation, then you'll be able to improve their quality of life, and that's been shown in many studies. Now, much has changed since I got out of medical school 30 years ago, and one of the things that has changed is our understanding of the mechanism of atrial fibrillation. 30 years ago, I was told that atrial fibrillation is due to multiple reentrant wavelets swirling through the atrium, that you needed on average 3.2 of these sort of rotors or these wavelets swirling through the atrium for atrial fibrillation to sustain. And what we've learned more recently is that the pulmonary veins are a common site for the trigger of atrial fibrillation. When I think of AFib now, I think about my snowblower, and even here in Baltimore we do have snowblowers. We might only be able to use them once a year, but I have a snowblower, and it has an electric start. So the pulmonary veins are the electric start for the snowblower. They are what starts firing and triggers atrial fibrillation, and then these reentrant circuits start swirling. Now, when you look at this fairly complex slide, you see lots of different colors. Well, the things in yellow are the autonomic ganglia. These autonomic ganglia are on the outside of the atrium, and we now know that they too play an important role in triggering atrial fibrillation. Why does AFib happen on a certain day, or while you're sleeping, or while you're exercising? Well, that's the importance of the autonomic nervous system and these autonomic ganglia. The little green things are what we call non-pulmonary vein foci. Not all AFib comes from the pulmonary veins or is triggered by the pulmonary veins. Some AFib is triggered from other sites. Now, I think we've also learned about the importance of remodeling. We've all heard the saying, AFib begets AFib. And we all know, or any of us that have spent a lot of time caring for patients, that the longer a patient is in AFib, the harder it will be to get them back to sinus rhythm. Or the bigger their left atrium is, the harder it is to get them back to sinus rhythm. And this reflects the remodeling that occurs when you develop atrial fibrillation. So you go into atrial fibrillation, the atrium's going 600, 700 beats a minute. Very quickly, you get electrical remodeling. The ion currents start to change, the action potentials in the atrium start to change. And pretty quickly, there's structural remodeling. The atrium starts to dilate, fibrosis occurs, you get cell death, and other remodeling goes on. And over time, the atrium gets larger. And again, any of us that take care of lots of patients appreciate this sort of remodeling or this dilation of the atrium that occurs over time. Now, we used to think that that was all there was to it. AFib begets AFib, and the more you have, the harder it is to get back to sinus rhythm. And this past year, a whole new concept has been really brought to the forefront, and that is called fibrotic atrial cardiomyopathy. So Hans Konkap from Switzerland is I think is one of the most ardent spokesman for this condition. Nasir Marouche in Salt Lake City, I think, also deserves a lot of the credit for highlighting this. But the point they're making is that it's not all AFib begets AFib. There's some patients that have relatively early AFib, early persistent paroxysmal AFib, and yet their atrium's terribly remodeled. They have lots of fibrosis on an MRI if you look at an MRI of the atrium, or if you just look at the size of the atrium. Even though this may be their first ever episode of AFib, their atrium's 6 centimeters. So the point that Dr. Kohnkamp and Dr. Marouche are making is you really have to think more broadly. How much is the atrium remodeled? How big is it? And that may be because the patient's been in AFib for a long time, or it may be because they have a fibrotic process in their atrium due to diabetes, due to hypertension, due to something we don't quite understand, but that significantly impacts the chance that you're able to control the AFib. And there's also data saying that the degree of structural remodeling, impacts stroke risk. So that's something else to consider. You have a patient that you're not quite sure whether to put them on anticoagulation or not. You look at the atrium's 6 centimeters in size. Well, in my mind, that tells you this is a remodeled atrium. You should be a little more liberal with the anticoagulants. Now, there's lots of things that are associated with AFib. The way I think about it is, AFib's rare before you get to the age of 50. You hit 50, starts to increase, and by the time you're 80, 1 in 10 people have AFib. We know that AFib's more common if you have heart disease, if you have hypertension, if you have heart failure. There's also new data really reminding us of the importance of sleep apnea. Lots of patients with sleep apnea have AFib. And when I see a patient in clinic, I'll sort of look at them. I'll turn to their wife or their husband and I'll say, does he or she snore? And usually the answer will be yes, particularly if this patient has a thick neck. And then I'll say, well, have you ever had a sleep study? Because more likely than not, the patient has sleep apnea. An important part of controlling their AFib is getting that sleep apnea under control. So these are just some of the things that are associated with atrial fibrillation.
Hugh, let me jump in real quick with a question. Very interesting question from Robert Rosenstein out in the audience. Now, there's a lot of data out there these days, emerging but controversial, that elite athletes or marathon runners, for example, might have some adverse effects from exercising so much. Maybe there's some stress on the heart, for example. So Robert Rosenstein asks, what about the incidence of AFib in elite athletes or those who exercise vigorously? Do we know anything about that?
Yes, I think there's more and more data telling us that elite athletes are more prone to develop atrial fibrillation. It's sort of counterintuitive. You'd say elite athletes, they're thin, they're super healthy, their blood pressures are great, but for whatever reason, the stress that comes with marathon running or being an elite athlete really does increase the incidence of atrial fibrillation. So I think it's one of the small prices that elite athletes pay.
Yeah.
Now, I think most of that atrial fibrillation could be treated, quite in a quite straightforward fashion. But I would say absolutely, there's a link between elite athletes and atrial fibrillation.
Yeah, it's really interesting. I know we see some increased subclinical atherosclerosis sometimes in these people, or at least vascular injury. It's interesting. Maybe we're not meant to run 30 miles repeatedly as a marathon runner would. I'm not sure.
Well, the other data that's coming out is data that in some elite athletes that right ventricular function starts to decline because the right ventricle is just not designed to, the right ventricular pressure is triple, the right ventricle dilates with exercise, and there's a new entity that's been described, by Hein, Heidelbuckel and others, really calling our attention to that, yes, athletes can get another condition called ARVD, but also, even in the absence of inherited cardiomyopathy, you can cause RV dilation and damage. But,
It's interesting.
so back to this link with heart failure and AFib, this is just a whole bunch of heart failure studies, with class 1 to class 4 showing the prevalence of atrial fibrillation. And I think it's striking, this rather linear relationship. The worse the heart failure, the more likely there is to have AFib. Obviously, the real importance of this is in some patients, heart failure is caused by AFib. And that may be one of the reversible causes of AFib. I think we're all aware of rate-related cardiomyopathy. Someone goes into AFib, they have a rapid ventricular response. Over weeks to months, they develop heart failure. And if you get that patient back to sinus rhythm, or you slow the ventricular response to the AFib, the heart failure can completely be eliminated. So this is something that clinicians don't want to miss.
Right.
In my mind, until you know otherwise, if you have a patient with AFib and cardiomyopathy, you should assume the AFib is playing a causative role in the cardiomyopathy and the heart failure. Try to control it and hope the heart failure, the ejection fraction, improves. Now, this is a slide that I just added recently when I give these AFib talks, and this is a great study from Australia where they studied the impact of obesity on AFib. And they took 40 sheep in Australia, and 30 they sent to the smorgasbord, all you can eat, molasses-coated grain, and 10 they sent out to the pasture. The smorgasbord sheep tripled their body mass, and the sheep out in the pasture stayed skinny. And what this study showed us is what the influence of obesity is. So what you see is all of the chamber sizes increase, the heart mass increased, the heart pressures increased. And then what I found most interesting is when you start looking at electrophysiologic measurements, conduction velocity and so forth, they also were slowed in the fat sheep. And lo and behold, the fat sheep started to get atrial fibrillation. So when I see a patient in clinic and they're overweight, I tell them about the sheep in Australia, and I would encourage you to do the same. And I really emphasize the importance of getting that weight under control. I mean, if they want to live a long and happy life, if they want us to get that AFib under control, they have to work with us and get that weight down. So this is something I really think is extremely important. So any other questions about sort of epidemiology or incidence of AFib or anything else that's come up, Mike, on the feedback we've gotten so far?
Nothing yet. We're hoping some more people ask some questions. But I wanted to ask a question real quick about, of course, we're appreciating obesity nowadays as an inflammatory condition. The adipocytes probably produce cytokines that are inflammatory, like in the metabolic syndrome, per se. Is the inflammation playing a part in atrial fibrillation incidence in the people with obesity?
Well, I think the thinking is that it is. I mean, part of it is when you look at that slide from the sheep, you see that all the pressures increased, the left atrial size increased, so the cardiac output increased. So obviously all of that is putting stress in the heart. But my understanding is that the inflammation also plays a very important role in triggering atrial fibrillation. I think the other important thing is when I see patients that are overweight that have AFib, many will end up getting catheter ablation. And I remind them when we do the procedure, the thinner they are, the less radiation we'll need to, to see the catheters in their heart. So if in the month or two they have to wait to get their procedure performed, if they can trim down, 20 pounds, I think that makes the procedure easier to go through, more likely to be effective. So again, I think this is really something that we all, even though it's hard to sort of bring up the conversation with a patient, or I find it difficult, I think it really is important to have that conversation. And this may be the wake-up call. And if even only 30% of patients get it and they lose 50 or 100 pounds, that's going to translate into a lot more.
Yeah, it's people. The teachable moment, I guess.
It's the teachable moment. You got their spouse there, they're there, and so forth. Hopefully they're paying attention. Okay, so let me move on and talk about treatment of AFib. And this is a very... the title of this talk is The Changing Landscape of AFib Management. And I think this is highlighted in no better way by looking at the various guidelines that have been published and that are soon to be made available. So we're all aware of the 2006 AFib guidelines published by the AHA, the ACC, and also the European Society of Cardiology. Valentin Fuster led this effort, a beautiful document. And it really, is in effect today. This is currently the main, AF guidelines, that have been produced by the United States. Now, shortly thereafter, in 2010, the Europeans decided to write their own guidelines. They have different medications available. They have different approaches, a different economic system. So they took the bold step to literally have a divorce with the AHA and the ACC, if you will. It was a happy divorce, but they chose to go their own way, and they wrote new guidelines in AFib, beautifully written a document. Then the AHA and the ACC with the Heart Rhythm Society came back and provided an update, a focus update, because there were some new anticoagulants, some new antiarrhythmic drugs were available. Then the Heart Rhythm Society wrote an updated consensus document on AFib ablation, on catheter ablation of atrial fibrillation. And I should say in the beginning of this talk, I said that I have no conflicts. I really do have a conflict. I was the first author of this document, so I'm highly conflicted, and I think this is a beautifully written document. So bear my conflict of interest in mind when I say that. Now, more recently, the ESC updated their 2010 document. Again, you get the sense of the ever-increasing pace of new knowledge and new approaches by the fact that the European Society of Cardiology would update their document 2 years after writing an updated document. And you may say, well, what about the AHA and the ACC? Well, you'll be happy to know they're doing a major rewrite of their 2006 document that should be published later this fall. So I think all of us should stay tuned, because when that document comes out, I think that will be very, very important to guide physicians in the United States on how to manage AFib and deal with some of these important management issues. So when you think about treated atrial fibrillation, there's sort of 3 legs to the stool. There's rate control, rhythm control, and anticoagulation. And this is not a Chinese menu where you pick 1 out of 3 or 2 out of the 3. This is a 3-legged stool where you have to think about each of these things. I'm not going to say that every patient needs a rhythm control strategy where you want to get them back to sinus rhythm, but you, the physician, needs to discuss it. You need to discuss it with the patient, and you need to understand the patient's preferences and values and so forth. So I think it's important to realize that each of these issues need to be discussed really in some detail when you're there, evaluating the patient, particularly as a cardiologist, a consultant. This is what your job is, to have a thorough discussion of all of these issues. Now, let me start out by starting with the most important, stroke prevention. As many in the field like to say, above all, preserve the brain. So let's first talk about stroke prevention. Now, when you look at the 2010 ESC guidelines, in this document, for the first time, they bring up a new stroke risk score system. I think we're all familiar with the CHADS-2 scoring system: congestive heart failure, hypertension, age over 75, diabetes, and stroke or TIA. But they brought up a new system, the CHADS-VASC system. So they add 4 different components to the CHADS-2 system. V is vascular disease. A is atherosclerosis, female gender. So they add a number of different components to the system. They add age between 65 and 75. So you end up with a total score being considerably higher. And when you think about these parameters, they're basically taking a more select population. They make the point that your risk of stroke doesn't suddenly skyrocket on your 75th birthday, that it goes up gradually from as you age from 65 to 75. So they said, look, we're going to give you 1 point if you're over 65, and then if you hit 75, you get 2 points. So this was something they brought up, and shown in this slide is the link between the CHADS-VASC score and stroke risk. They also came up in their 2012 updated guidelines with a very sort of simplified sort of approach to anticoagulation. They said, look, you don't have to count to 9 and calculate the CHADS-VASC score and so forth. You just have to recognize who's the low-risk patient that doesn't need anticoagulation, and everyone else should be anticoagulated. So what this guideline walks you through, it says, well, if you have rheumatic heart disease or a prosthetic valve, well, you need to be on anticoagulation with warfarin. And that if you don't, you then assess the CHADS-VASC risk score. If your CHADS-VASC risk score is 2 or greater, you need to be anticoagulated. If it's 0, you don't. And if it's 1, it's a dotted line, it's a 2A recommendation. Their leaning is to encourage you to anticoagulate the CHADS-VASC score of 1 patients. And then they go so far as to show that there's a preference for the novel anticoagulant drugs. We know we have warfarin, and then you have all these new drugs. You have dabigatran, and you have rivaroxaban, and you have apixaban. And they make the bold move to say there's a preference for the novel oral anticoagulant agents. And I think that reflects the fact that many of these studies have shown that these newer drugs are more effective than warfarin. So it's not an issue that they're just equivalent, which do you prefer, but they're more effective, or some of them have been shown to have a lower bleeding risk. And they certainly are more convenient, so compliance is better. So they've made that bold move. Now, what the AHA and the ACC are going to do, we'll know in the fall, but I think this was a very important document, a very bold document. And I think the concept, which they're really emphasizing, which I quite frankly have bought into, which is, if someone's really low risk, they don't need to be anticoagulated. But if someone starts having stroke risk factors, age over 65, you really need to anticoagulate them. And because the only mistake you could make is by not giving them anticoagulation. Now you may also wonder, well, what about aspirin? Aspirin's nowhere on this figure, and they make the point that aspirin's not an anticoagulant; it's an antiplatelet. Aspirin really does very little to lower stroke risk, and we'll go over that in more detail in a moment. Now here are their specific recommendations from their document. Again, this document's very well written, very concise. I think this is a very good table that makes the point. And if you look at the very bottom line, they talk about the aspirin. And they basically say if a patient refuses warfarin, if they refuse anticoagulation, one of these novel drugs with an anticoagulant, with one of the novel drugs or with warfarin, then you can consider aspirin, or preferably aspirin and Plavix, because that's been shown to be more effective than aspirin. But they really make the point that aspirin is not an anticoagulant, and I think we need to get this message really out, that everyone likes to think that aspirin is no risk of bleeding and is wonderfully effective at preventing stroke. Well, that really is not the case. Now, you can see when we talk about changing landscape, if we go back to the AHA-ACC guidelines, this is what currently is recommended by the AHA and the ACC. They say if you're low risk, if your CHADS 2 score is 0, you get aspirin. If you're moderate risk, your CHADS 2 score is 1, you get aspirin or anticoagulation. If it's 2 or greater, you get anticoagulation. You can see how different these recommendations are than these new ESC recommendations. And I predict, I'm on the writing committee, but I can't tell you anything, but I suspect that some of these recommendations may change, and we'll just again have to see what comes out when this is finally published, in the late fall. Now you may say, well, why did the ESC make all these changes? Was there any rationale for them? Well, this is a wonderful study I love to sort of cite. This is a study that comes out of Denmark. And in Denmark, one of the things I've learned is that healthcare is free in Denmark, and that everyone's in sort of a national healthcare system, and their outcomes are tracked, so they can do small studies like this. They took 75,000 patients that met the inclusion criteria to look at the link between stroke risk factors and the risk of stroke. So again, a small study, only about 75,000 patients from our friends in Denmark. And this is what they saw. Now, if you look at these two schemes, on the left is the CHADS 2 risk score system. So you have the CHADS 2 score of 0 through whatever 6. And on the right is the CHADS VAS risk score. And as you look at the stroke risk, the annual stroke risk, and you sort of imagine if you were a patient with a CHADS 1 risk score, you can see that the CHADS VAS risk scoring system is basically much more stringent. If you're a CHADS VAS of 1, your stroke risk is less than half than if you're a CHADS 2 score of 1. It's just a much more sensitive parameter. And the question I ask you is, if you were the patient, how much risk of stroke would you be willing to accept each year? 1%, 2%, 3%, knowing that most strokes will either kill you or will land you in the nursing home and change your and your family's life forever. So I think but this is really where the CHADS VAS risk score, how it was validated. And to me, I'm convinced that the CHADS VAS score is the way we need to go. Now, the next question that comes up, the ESC document made a big change on, is to say, look, aspirin's not an anticoagulant. It's an antiplatelet drug. and only use it if someone refuses an anticoagulant, and because it really doesn't do much. And so, when you dig through the data on aspirin and anticoagulation, this is from the very famous Heart meta-analysis where they took all the published studies comparing aspirin to warfarin. And this shows the results of those studies. Now, if you look down these studies, when the point estimates, the little circle, and then those things that stick out to the side, I know statistician, are sort of the error bars or the confidence of the recommendation. And when you look at those, you can see that every single one crosses the midline. And I know, Mike, you have training in statistics and public health and all this, so maybe you can clarify this. But my take as a mere clinician is that only one of these studies were the error bars below the neutral line, meaning only one of these studies definitively showed that aspirin was superior to warfarin. Is that correct, how we should interpret this?
This is, I think, an important slide because it tells you what the importance of meta-analysis is. Meta-analysis is valuable in some circumstances where you have a suggestion that a treatment might be beneficial, and that's what you see here. Each study shows the point estimate shows a benefit with aspirin, but just one study showed a significant reduction in events. But grouping those together, we see a small, mild effect for aspirin improving outcomes that's just borderline statistically significant.
So then I think it's fun to say, well, let's dig out this great study, this SPAF study. We've heard about all the studies of the new anticoagulants, 15,000 enrollees, whatever. Let's look at this famous SPAF study, the one that showed, that this was clearly, effective. Well, here's the study. Now, as you look through, there were two groups. The study was a small number of patients, literally hundreds of patients, not thousands of patients in each arm. And in one of the arms were patients that were warfarin eligible, and the other arm were warfarin ineligible patients. So if you look at the warfarin eligible patients on the left, and you sort of scroll through and you follow the data, you can see that aspirin was fantastically effective. It reduced, the stroke risk by, greater than 90%. And then you look in the other arm. These were the patients that couldn't take warfarin, so they were just randomized to aspirin and placebo. And in the other arm, there was absolutely no difference. So you add it all together, you end up with a statistically significant difference, but it just doesn't smell right to me. But now, Mike, you're the expert. How do we help us understand what this tells us about aspirin as an anticoagulant? How much confidence should we give in this study?
Well, I think that you made the most important point, which is the people probably in the anticoagulation eligible group, maybe, or some of the higher risk patients got benefit with therapy, but those are the patients we're going to be treating with anticoagulant drugs. In the other group, the ones we might be considering aspirin, we didn't see a lot of benefit. So the subgroup that's probably most clinically relevant didn't really show much of a benefit.
Yeah, so anyhow, so I think this is important. And then the final nail in the coffin, if you will, this concept that aspirin is so great because it doesn't have any risk of bleeding. Well, if we look at one of the recent studies, the Averroa study, compared apixaban and aspirin in patients with AFib and looked at the stroke risk on the left and bleeding risk on the right. And what is striking is that apixaban dramatically reduced the stroke risk compared to aspirin, with no difference in bleeding risk.
Right.
So if you were the patient and you're trying to choose between aspirin and one of these new anticoagulants or anticoagulation, to me this tells me, well, I'm going to go with a drug that's going to lower my risk of stroke, that's going to give me the same risk of bleeding as aspirin. So I think this is also important to keep in mind. Okay, so let me just move on now. So there's limitations to warfarin, which I think we're all aware of. It interacts with your diet, how much vitamin K you use in your diet. Some patients, it's very hard to keep the level in the therapeutic zone. It takes a while to get an effect. It takes a while for the effect to wash off. So we're all aware of the limitations of warfarin. And the good news is there's all these new anticoagulants that have become available. The factor Xa inhibitors and the direct thrombin inhibitors. Now, the first drug to be approved was the direct thrombin inhibitor, dabigatran, followed by two Xa inhibitors, apixaban and Xarelto. And again, these I think are a major sort of advance, these new and novel anticoagulation agents. Now, let me move to the next slide. Now, when you run through these studies, dabigatran was the first study to be approved, and this is the study that got it approved, and it compared 2 doses of dabigatran to warfarin. 150 twice a day and 110 twice a day. This was a study involving literally more than 15,000 patients. So when we look back to the last study we looked at with aspirin, look at this study. This is a really impressive study, and you can see that dabigatran was not only as good as warfarin, it was superior to warfarin, and this is why the ESC guidelines gave it a preference that these novel anticoagulate agents, that dabigatran is really preferred over warfarin, really based on the data. And again, 15,000 patients with no difference in bleeding risk. Similar results were seen with rivaroxaban. It did not reach significance in terms of benefit. It was equivalent to warfarin, but again, one of these new drugs showing that it's equivalent to warfarin in terms of anticoagulation. And the most recent is apixaban. Apixaban showed superiority. It was a slightly bigger study than with Xarelto, but again, lower risk of stroke, lower risk of bleeding. So again, we have a lot of these new anticoagulant agents now available. So let me just move on to the other. Actually, let me stop there and see if there's any questions about anticoagulation or issues that have come up.
Yeah, so a good question, a couple of good questions came in. A viewer named Alice asks, always an important clinical question, how do you assess bleeding risk? How do you assess bleeding risk? And she asked specifically, how do you assess fall risk, maybe in an elderly patient?
Yeah. Well, there's a number of different scores now available to assess bleeding risk. One of the ones that is most widely used is the Hasbled score, which looks at various parameters and to identify uncontrolled hypertension, you're at increased risk of bleeding, age and so forth. And I think I think some people misinterpret these bleeding risk scores to say, oh goodness, my patient is at high risk of bleeding based on the Hasbled score, I'm going to give them aspirin. Mm-hmm. Well, that's completely the wrong approach, because just because they're higher risk of bleeding, they're also higher risk of stroke. Mm-hmm. And so it's some of the patients that are at higher risk of bleeding that are at the highest risk of stroke that you absolutely need to anticoagulate the patients. And I think how you should use these bleeding risk data is to say, if there's controllable risk factors, we need to control them. So if a patient has uncontrolled hypertension, well, that's a risk factor for bleeding. Right. So yes, that patient's at high risk for stroke. You really want to control that hypertension to modify that risk. Patients, you may want to follow them more frequently if they have a high bleeding risk score. But I think it's a common practice for some physicians to say, oh, Mrs. Jones is 80 and she's fairly frail and she could fall, and if she falls, she could bleed on one of these new drugs, so I'm going to give her aspirin. Mm-hmm. I think that's a big mistake, because the data says the older you are, the higher risk you are. These frail older patients, they're the ones at highest risk of stroke. They're the ones that need to be anticoagulated the most. And if you look at the studies that were performed with these new drugs, they were comparing warfarin to these new drugs, and again, the new drugs were either equivalent or superior. I think too many physicians look for excuses not to anticoagulate patients. So I think you really shouldn't do that.
I see that all the time personally. Alice had another question. This is a difficult one to answer, I know. But in terms of the new agents, of course, monitoring is difficult, and specifically brings up the situation about preparing for surgery if someone is on one of these new anticoagulant drugs. What monitoring options are out there? When do we ever use anticoagulation monitoring, if ever?
Yeah. Well, I think there's two things that I think should be discussed. One is this discussion that everyone talks about, that these new drugs have no anecdote, that you can't reverse them instantly. Mm-hmm. Someone comes in, they have significant bleeding, they're on one of these novel drugs, you can't give them vitamin K, you can't reverse the drug the way you can warfarin. And so I think many physicians and patients use that as an excuse not to use these new drugs, and that's another huge mistake. When you look at the trials that were done with these novel oral anticoagulant agents, and when you combine them, there are probably over 60, 70,000 patients in these trials, and there's been hundreds of thousands of patients. ever since. There are not patients, when you compare warfarin to the new drugs, bleeding to death from, on the new drugs where they did fine on warfarin. In fact, there's really no difference in bleeding risk or the number of patients that bled to death on warfarin versus the new drugs. We like to think, oh my goodness, someone's in a car accident, we can turn off warfarin instantly. Well, in fact, it never has been proven that you get a patient to the hospital and that by somehow reversing warfarin immediately you change their outcome. And in fact, the studies show, no, people are not bleeding to death. So I think that people just need to get that out of their head. It's not really a concern. All these drugs reverse, over time. In terms of monitoring, the half-life of these new drugs is short. It's about 12 hours. So usually you'll stop these drugs about 2 days before surgery. If they have impaired renal function, you might stop them a little bit longer. Whether you bridge them will depend on the risk of stroke and so forth. But I think they really make the whole bridging very easy. You stop them 2 days before, do the surgery. After invasive procedures like catheter ablation, we restart them, 4 hours afterwards. Okay, so I've got to get moving. I only got a little bit more time of things. I want to have some time for questions. So rate control, it's just important. The way I approach rate control is their average heart rate on a 24-hour Holter should be less than 100. I think that's the general number that I use. In terms of rhythm control, we have antiarrhythmic drugs. We've all seen the flow sheet based on which drugs to use in which patients, and this is really based on risk profile. If someone has ischemic heart disease, you don't use the 1C agents. We now know if someone has heart failure, you don't use dronedarone. You don't use, you're limited mainly to amiodarone if they have significant heart failure. But I'll leave this to you to sort of look at after the lecture. Just be realistic in terms of your recommendations. One recurrence of AFib does not mean you go to the next drug. If they just have one episode a year, that may be perfectly acceptable. It's about quality of life, AFib burden, if you will. Catheter ablation, my colleague Dr. Marine will really be talking a lot about catheter ablation. I think we all know that it's all about isolating the pulmonary veins, and wherever you go in the world, most operators will do it the same way. For those really interested in catheter ablation, look at that wonderful AF ablation consensus document, which is a great review. There's currently two FDA-approved systems, the Thermocool, the irrigated catheter, the cryo balloon, the freezing balloon, and there's some other investigational systems that are being worked on. These catheter ablation successful in about 2/3 of patients. And when you say, well, what are the results in 2013? This is my assessment. So I think you have to break it down to single procedure success and multiple procedure success. I think too often physicians like to sort of sugarcoat the results, and they tell the patient the multiple procedure success, and they forget to tell them that's with multiple procedures or multiple procedures with drugs. In an optimal candidate, paroxysmal AFib, pretty young, healthy person, 60 to 80% single procedure success, AFib-free at a year. Moderate candidate, 45 to 65. Poor candidate, 35 to 50. With repeat procedures, efficacy goes up. Late recurrences occur. This is not WPW ablation, but Dr. Marine will fill you in more. Complication rate, 1 to 3%. I'm going to skip over the indications. I hope Dr. Marine will have time to cover that in his talk. So in summary, I just want to summarize that when you think about AFib, it's a three-legged stool. In every patient, you assess their CHA2DS2-VASc risk score. If their CHA2DS2-VASc risk score is 2 or greater, absolutely anticoagulate them. If it's CHA2DS2-VASc of 1, the only one that you sort of is a pass is a female gender. If that's their only risk, I wouldn't anticoagulate them. The rest, I err on anticoagulating them. You can look at the size of their atrium, other things. Patient preferences are very important. Rhythm control, discuss it with the patient. I believe in rhythm control for most patients, and rate control, make sure their ventricular response is adequately controlled. So I'll just conclude that AFib is a common arrhythmia. The landscape is changing. The guidelines are changing. There's lots of things to think about, and it was really wonderful to be here with you this morning.
Yeah, so we have a few quick questions we'll try to run through real quick. Some of them most of them are based on treatment questions. And wonderful presentation. We have lots of compliments coming in from the internet. Okay, let's start off with a question about amiodarone real quick. Paul asks, would reducing a maintenance dose of amiodarone from, let's say, a higher dose, like 200 to 100, does that appreciably reduce side effects in your experience?
Oh, I think absolutely. The side effects of amiodarone are largely dose related. So, 400 a day. I mean, I usually will put a patient on 400 a day for a month, then drop it to 200 a day, and leave them on 200 a day if they're doing well after 6 or 8 or months or a year. Absolutely, I try to get it down to 3 times a week or 100 milligrams a day. I think the lower you can go, the better, because most of the side effects are dose related. Good point.
Yeah, great question. Another good question coming in. Someone's asking, coronary disease, of course, is some consideration you have to make with flecainide, of course. What about a revascularized asymptomatic patient? Can flecainide be used?
Yeah, I would say no. I would say anyone with coronary disease, known coronary disease, you shouldn't use flecainide or propafenone, because we know that if you're on those drugs and you get ischemic, you occlude the graft, you occlude the coronary, whatever, you pop a plaque, that if the setting of ischemia and those drugs has a much higher threshold for VF occurring. So I'd say no. I do not think well revascularized coronary disease, those drugs should be used in those patients.
Okay, great. Let's do another quick one. This is a great question, once again from Robert Rosenstein. I experienced this certainly in my training. How long do you continue anticoagulation after ablation? How do you make those decisions after ablation?
Well, I mean, the current consensus document is that everyone after ablation should be anticoagulated for at least 2 months during the healing phase. And then the consensus document and the guidelines say that at 2 months, decisions regarding anticoagulation should be based on the patient's stroke risk profile, their CHA2DS2-VASc risk score, and not the perceived presence or absence of AFib. And that reflects the fact that, one, we know AFib can occur late after an ablation procedure. Just because you're doing well at a year doesn't mean it's not going to be back in 2 years. When it comes back, it's more likely to be asymptomatic. And over time, patients pick up CHA2DS2-VASc risk factors. They get older.
Right.
So until we have better data showing that you can safely stop them, the guidelines and my recommendation is to say you recommend they continue them. If a patient says, look, my preference is to stop them, I'm willing to accept X amount of risk, that's a discussion between you and the patient. Be careful to document that discussion in the chart.
Yeah, great point. Let's do one more quick question. Luciano in the audience asked, looking at some of the slides, I think was trying to figure out what your recommendation would be for use of Holter monitoring, and I guess to look for asymptomatic paroxysmal AFib burden.
This is post-ablation or in all patients? Or
Yeah, let's say for a patient who had one instance of atrial fibrillation, a middle-aged person, and then comes to your office in sinus rhythm. Do you try to monitor the burden of AFib at all?
I think AFib burden is a very interesting parameter and very useful when you think about clinical trials and so forth. I wish every study had like a 7-day Holter monitor where you had continuous AFib burden repeated now and during follow-up. Because when you look at sort of the definitions of success of AF ablation, we have a very high definition in clinical trials. One recurrence, 30 seconds or longer, symptomatic or asymptomatic, we call the procedure a failure from a scientific standpoint. From a clinical standpoint, that patient may be as happy as can be,
Right.
and that reflects AFib burden. You get someone from AFib all the time, 100% burden, to 1 episode a year, 0.1% burden, they're happy. And so I think it's a very important clinical parameter to use when considering your patients.
Yeah, great. Well, thank you, everyone, for joining us. And I would like to thank Boehringer Ingelheim Pharmaceuticals for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for Joe Marine's talk on patient selection, the key to optimizing outcomes with ablation therapy, where we continue this discussion and talk about ablation therapies. Once again, my name is Dr. Blaha, and thank you for joining us on Cardio Care Live.